It seems these things don't kick in until 2014, and the hospitals with the worst records have a very small penalty. It all seems so tentative and delicate. Whereas if you start saying no Medicare money, if you goof,
Exactly.
it'll clean up.
Exactly. Transparency is needed in Wall Street, and transparency is needed in medicine. You should be able to know your doctor's report card. You should know how many surgical procedures he's done and how well the patients fared. The mortality when David Axelrod published figures for bypass surgery was as low as less than 2%. That was at some of the hospitals, NYU in particular, St. Francis, as high as 10%. And as a matter of fact, when hospitals had a 10% mortality for bypass, the procedures were stopped. And the reason for the high mortality was totally related to the number of procedures they did. And the numbers I used before were actual. One hospital who was doing 300 bypasses per year had 30 infections. A hospital that was doing 3,000 procedures per year had less than 1%. So you experience, and all one has to do is to go into a great hospital like St. Francis. And by the way, I'm not on the staff at St. Francis, so this is not.
I was in St. Francis, and I had great respect.
Exactly. This is not a paid commercial. I was only a patient in St. Francis.
Well, let me tell you a brief story about that. At Stony Brook, they were throwing 24 pills at me before dinner. And one of them was a stool softener when I had diarrhea. And you got to laugh about that. But then I went to St. Francis, and within a day they cut back to 8. I mean, they really did a good thing. But I just want to remark on this. I have talked to a person who's been a member of the Joint Commission Board for over 10 years. And this person told me there has not been one disaccreditation, and the Joint Commission accredits 80% of hospitals for safety reasons, not one from the Joint Commission. How are they in this position where the government is authorizing them?
The only thing the Joint Commission will do if you have an infection or a lot of infections, for instance, there was an outbreak of staph in the pediatric ward at NYU some years ago, and children were dying because of this. They closed the ward and wouldn't open it until they cleaned up their act. I think that your point is really an excellent one. The best way to have a hospital or a doctor clean up his act is don't pay him if he doesn't perform well. And by the way, the other half of the coin is pay him better if he does a good job. You'll see how often they do good jobs.
How did you become such a revolutionary?
I don't know that I'm necessarily a revolutionary. I was a patient and I almost died. And I'm old enough to have discussed World War II with you. So we go back to a common history. I think that as you get older in medicine, you sort of become interested in the bigger picture. And the bigger picture is helping as many people as you can. I still practice rheumatology in Massapequa. I help one patient at a time. But certainly I would love to help many more patients at a time.
What is going on in the academic area? I have friends who were prominent academics, some still are, and they speak very much as you do, but they never go public. You ask them to write a letter to the paper, the local paper or something like that, oh no. There seems to be a sort of guild mentality that stops speaking out.
There's a cliche that I've been using, let's see, probably for the last 10 years, and the cliche is I'm too old to lie, okay? And it's so. I speak out.
But you don't have to speak out without you.
Well, I do speak out if I think that it's going to do some good. I testified, for instance, at the New York State Senate hearings on exactly this point, on hospital infections. There are many more physicians just like me who, if they could affect some good, certainly would do it. I'm very
sure.
Oh,
I'm
absolutely,
sure.
absolutely. They just don't have the media, the opportunity. They don't sit down and write letters, but they feel the same way that I do. And I think that there are many reasons for going into medicine. High up on the list is ability to help people. I mean, there's nothing more gratifying than helping people, and the more people you help, the better you feel.
Well, you write in your book you've saved only one life. Now, that's a fascinating thing to say, because I know of doctors who feel that they've saved many lives.
No.
But what you're saying is it's up to us to a great extent.
It's entirely up to you. You must be your own advocate. You must realize what it is that's going on. You can't just go to a doctor and have him treat you for things that he doesn't know anything about. You can't go to a general practitioner who sees 100 patients a day and expect him to know everything there is about rheumatoid arthritis or about lupus. You can't go to a general practitioner, and I'm not knocking general practitioners. I mean, most of them do a really great job. A lot of them see too many patients, they're too busy. I know of a pediatrician, and by the way, this is a fairly ubiquitous phenomenon, who see 100 patients a day. Now, you tell me how you can see 100 patients a day. You can see 100 patients a day, but you certainly don't know what's going on. I think that the answer to a problem is quality medicine, and quality medicine can't be done with volumes. And the reason that there are so many doctors are seeing so many patients is insurance cuts, insurance cuts, insurance cuts. Insurance is paying less and less money for all sorts of procedures. I just received a notice from an insurance carrier, and I'll tell you, it's Blue. It was Meta Blue that said to me, had the nerve to say to me, to write me a letter refusing a bone density. Now, my specialty is rheumatology, but part of that is osteoporosis. A bone density is an essential part of the examination. They had the nerve to say to me that the bone density was not approved because it was an experimental procedure. Now, the only reason they did that is so they wouldn't have to pay the bill. The major incentive for insurance companies is to give the doctor and the patient less and less reimbursement. They're in business to make a living.
Is that going to improve under the new health care program?
I have to tell you that in contradistinction to many of my colleagues, Lyndon Johnson was one of my heroes. Lyndon Johnson brought Medicare in. I think that eventually, if the government can control the insurance companies, the pharmaceutical companies, we'd have better medicine. It bothers me so that how much was the medicine that you took that cured you?
It was $1,000.
Okay.
$1,012.
Okay. What happens if you don't have $1,012?
Right.
And I see that all the time. I deal with drugs that run $20,000 a year that have revolutionized the treatment of rheumatoid arthritis, and yet patients are not covered for it, and the patients can't possibly afford it. Now, that shouldn't be. It should not be in this country in this year that there is available a therapy that works perfectly, that a patient can't afford. The government should step in and do that, and that's not happening.
Right. Well, this has been wonderful having you here. We're down to about 45 seconds, and I really want to thank you for coming here.
It's been my pleasure.
It's been such an enlightening discussion here, and we're very, very grateful for you and your book and what you've done. So thanks very much, and have a nice day.
Thank you,
Oh,
Reggie.
one thing.
Sure.
One word you never used that I've always heard a doctor use.
What's that?
Appropriate. You did not use the word appropriate, and that's made me very happy.
Well, okay. I'm happy I didn't use it. Why does appropriate upset you?
Oh, it just becomes such a cliche.
Okay.
It's applied everywhere.
Right, okay.
Appropriate, inappropriate.
Well, all right, okay. Appropriate covers a lot of sins.
Yeah. Most cliches do.
Exactly, precisely,
Most
absolutely.
cliches do. All right. Rheumatologist, professor at Stony Brook. Been fine having him here.
Thank you, sir.